Our speaker is Dr. Robert Lewis. Rob recently joined the Hoag medical staff as a neurosurgeon and has become the program director for skull base and pituitary tumors. As you know, programs, as we define them at Hoag, are multidisciplinary teams focused on a particular patient condition, and they live in various institutes. The Neurosciences Institute has a number of programs, including stroke, including epilepsy, including movement disorders and Parkinson's, back pain and spine surgery are some of our programs. All of them are multidisciplinary. Multiple specialists live in the program, focusing on a particular patient problem. As mentioned, Rob is the team leader for a group of neurosurgeons, neurologists, endocrinologists that have gathered, as well as neuroradiology and obstetrics, primary care docs, obstetricians, because a pituitary tumor often presents as prolactin secreting and can make galactorrhea, the manifestation that is being presented to an obstetrician as an example. So the multidisciplinary team has some accountability for patient satisfaction, patient outcomes, and the affordability of managing that disease. So that's how we approach our care for patients increasingly these days on a programmatic theme, if you will. Rob trained at the University of Virginia, one of the meccas of neurosurgery in this country. I would say one of the top 4 programs in the country. Many chairmen of neurosurgery departments come from training in the University of Virginia, and that program is in the world of neuro is highly acclaimed as generating just superb neurosurgeons. We're lucky to have gotten him. We were in competition with some folks up north, but he decided to come here to be our program director and has already dramatically improved the care of our patients, most of whom traveled up to LA with pituitary tumors, because the special skills you'll hear about to address those reside in relatively few hands. Now, Rob, after the University of Virginia, actually spent a fellowship up in LA with one of the masters of pituitary surgery, Dan Kelly, who we tried to recruit, but Dan is too busy and too entrenched in LA to have made it down here, so he sent us his wingman, actually Rob's probably going to cost him some business, because now our folks aren't going up to LA anymore because they can get world-class care right here. So with that introduction, I'd like you to meet our speaker for the day, Dr. Robert Lewis.
Thanks everybody for coming today. I know it's a beautiful day outside and there's probably places you'd rather be, but I appreciate you coming and giving me your attention for a few minutes. So we're going to be talking about the evolution of the diagnosis and management of pituitary tumors. Unfortunately, I have no juicy contracts to disclose. Hopefully, maybe someday I will. But so we're going to be, just to brief overview of what we're going to be talking about today, a brief epidemiology of pituitary tumors. Then we're going to go through the clinical presentation, what would you see as a practitioner. We're going to go back in history a little bit and review the evolution of the surgical approach to pituitary tumors, and then discuss advances which have led us to the modern 21st century technique. I'm going to talk a little bit about our steps and where we are as far as establishing Hoag as a center of excellence for pituitary care, and this is one of my primary goals. And then we're going to finish off with a case presentation. So how common are pituitary tumors? Well, it's estimated based on autopsy studies that approximately 15% of the population will have a tumor in their pituitary gland at the time of death. So if you cross-section everyone's gland, you get about 15 out of 100 will have tumors. However, the vast majority of these are microadenomas and asymptomatic and do not require treatment. This is a pie graph of the distribution of 300,000 primary brain tumors and the breakdown of that by tumor type, and pituitary tumors account for about 15% of all primary brain tumors. You can see the biggest piece of the pie here is meningiomas, which is about 35%, which is also something we with the skull-based program are aiming to treat. So we're looking at approximately, between the two, about 50% of all primary brain tumors are located within this group of pituitary tumors and meningiomas, which the goal of the skull-based program is to treat. So breaking it down by age, it's a little more impressive that In the 15 to 35-year-old age group, tumors of the pituitary are the most common primary brain tumor. So this is affecting people of young age and has a significant ability to affect their quality of life and cause neurologic and hormonal morbidity. And then in the next age group, 35 to 55, also working age people, these are the second most common pituitary type of primary brain tumor, behind, again, meningioma. So this comprises quite a large portion of the primary brain tumor histologies and requires, as you'll see, specialized care to treat them. So if you break it down based on incidence per year, we're looking at about 11,000 new cases of pituitary tumors in the United States per year, and that equals out to about 1,200 new cases per year in California. And this includes patients that need surgery, that require surgical treatment. It does not include medically treated or conservatively managed patients. There are three main ways which pituitary tumors can cause symptoms. The first one is hormonal overproduction, and there are several syndromes which tumors can oversecrete different hormones and result in these overproduction syndromes. If in the case of Cushing's disease, it's ACTH, so results in hypercortisolemia. In the case of acromegaly and gigantism, it's growth hormone. In the case of prolactin-secreting tumors, it can result in amenorrhea and galactorrhea syndrome. We'll go a little bit more into these in more detail. And then thyroid stimulating hormone, which is relatively rare but can be a very severe cause of hyperthyroidism. So that's hormonal overproduction is one. The second way they can cause symptoms is through pituitary malfunction, so compressing the normal pituitary gland and causing it to not produce the hormones that it should produce. And this happens in a relatively stepwise fashion. Fortunately, the cells of the pituitary gland which are most necessary for life, the corticotrophs, the ones that secrete ACTH, are the hardiest, so they're the most resistant to compression. So if you were to take a tumor and squish the pituitary gland, the cells that would stop functioning the first are the growth hormone secreting cells. You don't need growth hormone to live. You can live perfectly fine without it. You don't feel great. You don't have a lot of energy, and you'll age more quickly, but you can live without it. Also, the gonadotropins, LH and FSH, the cells are relatively feeble and easily disturbed by compression. Therefore, those cells stop producing their products relatively early in the stage of compression from pituitary adenoma. The hardier cells, the next one up is thyroid secreting hormone, TSH. So these cells are kind of an intermediate spectrum. You need thyroid hormone to live, but you can live about 2 months without it. So those cells, they're a little bit hardier, but they will get compressed and stop functioning as the tumor gets larger. Finally, the corticotrophs are the hardiest, and you'll live about 2 days if you don't have cortisol. So fortunately, evolutionarily, the gland has kind of prioritized itself in order to make the cells which we need the most hardest to destroy. So that's pituitary insufficiency, and this oftentimes goes for many years without being diagnosed because the symptoms are subtle: lack of energy, fatigue. These kind of things are very common for many conditions, so a lot of people wouldn't think to check patients' pituitary function, particularly their sex hormones and their growth hormone function. The third way is by mass effect on surrounding structures, and this is the ones that a lot of people have heard of, particularly compression of the optic chiasm causing visual loss, as well as the third and fourth and sixth cranial nerves on the lateral edge and the cavernous sinuses, causing double vision. Also headaches. These get large enough, they irritate the dura, they cause headaches. So it's easier to understand this, why they cause the symptoms that they do, when you look at a cross-section of the cella. This is the pituitary gland right here in the center, directly the pituitary stalk going up towards the optic chiasm above. So it doesn't take much growth, up to maybe a little bit bigger than 2 centimeters, this tumor will be, and it'll start to compress the optic chiasm, causing visual loss. It takes a little bit of a bigger tumor to extend laterally, compressing the cavernous sinus. The carotid arteries, which lie here, cranial nerve 3, 4, V1, and 6 are here. And these, it takes quite a large tumor to cause double vision, whereas it doesn't take so much to cause the visual loss associated with chiasmal compression. So this is we've all seen these visual charts. We're talking about when the pituitary tumor gets large enough, it compresses the optic chiasm, resulting in the pattern of bitemporal hemianopsia. The temporal visual fields are represented by the nasal hemiretina, which then the blue fibers on the right side cross here at the chiasm and represent the contralateral visual field. So as those nasal hemiretinal fields are crossing and getting compressed, they result in loss of peripheral vision. Interestingly, many patients patients don't notice this. You'll ask them, maybe in retrospect, have you noticed that you've been kind of bumping into things and you haven't really noticed it? I bump into the table in my living room all the time, and I just didn't really think anything of it. And the visual loss can be relatively profound by the time they present to their primary care physician or to an ophthalmologist for formal exam. This is the pattern of visual loss you'll typically see. This is a dense bitemporal hemianopsia, so the right eye sees loss of the right temporal field and the left eye sees loss of the left temporal field. And this is pretty debilitating, although again, patients often don't notice it. They just kind of have gotten used to it over time. So that's one way, mass effect to the visual loss of peripheral vision. The second way that is with these functional tumors. So Cushing's disease causing hypercortisolism. This is due to excess secretion of ACTH, or the precursor to cortisol, from these small tumors. These are most often, when they're discovered, microadenomas. So these are tiny tumors, but they're the most common cause of endogenous hypercortisolism. So Cushing's syndrome can be if you give your patients too much steroids, they get Cushing's syndrome, the characteristic features. But if it's an endogenous source, a pituitary tumor secreting ACTH is the most common cause. Also, acromegaly and gigantism we're going to talk a little bit about. These result from excess growth hormone production, and depending on where you are in life when you get it, will determine which of these two syndromes you get. Prolactinoma is unique in that it's the only it's the only type of tumor that's treated primarily medically. There is dopamine agonists which are used to treat prolactinomas, and very successfully. Approximately 90% of the time we can get away without surgery for prolactinomas. And again, thyrotropinomas are very rare. To look a little bit more in depth at these conditions, Cushing's disease is something I have a particular interest in. My mentor at University of Virginia, Ed Oldfield, is the kind of world guru of Cushing's disease. He's done over 1,000 Cushing's cases. I did almost 300 in my residency with him. And this tumor are often 2 to 3 millimeters in size, and yet it's the most destructive tumor known to man, gram for gram. Because a 2 or 3 millimeter tumor will cause these patients to lose 20 years off their lifespan if it goes undetected. The wide-ranging systemic consequences they have from excess cortisol is absolutely devastating to these patients. Metabolic conditions, including obesity, diabetes, and hyperlipidemia, these are things that are very common and most often not caused by Cushing's disease, but in patients that have refractory metabolic syndrome, at least worth investigating. Catabolic conditions, they get thinning of the skin, poor wound healing, osteoporotic fractures, easy bruising. Cardiovascular conditions, coronary artery disease, stroke. These things these are occurring in people that are in their 40s and 50s, not typically when they occur in their 70s, 80s. Neuropsychiatric conditions, emotional lability is one of the most commonly described things. You may have seen a patient that's been on steroids for a long period of time, and they have these kind of up and down mood swings that's relatively common in these patients. Hyperandrogenic syndromes, they get also as a result of the excess cortisol, they get extra testosterone production, and so they get hirsutism, acne, and oligomenorrhea. And then, as we discussed, decreased function of the pituitary gland itself, resulting in delayed growth for children and hypogonadism. So these are typical findings of a patient with pituitary disease. This is a relatively dramatic example of the thinning of the skin, the striae that these patients get, and this is, there's nothing else that causes this really other than Cushing's disease. Again, this is a picture of someone's face. Obviously the hirsutism, the round faces, or we call moon faces, hirsutism on the chin, and the acne. These are all very classic features of Cushing's disease. By comparison, acromegaly, also very classic features. This is a very good example of that, the enlarging of the jaw, the frontal bossing. The surface features of acromegaly are well known, but this isn't what causes them morbidity and mortality. What ends up that you see on the outside, you see the overgrowth of their bone and their soft tissue, is happening on the inside as well. Particularly the cardiomegaly in these patients can be profound, and that, unfortunately, is irreversible. So it's really important to catch these patients early. So acromegaly is when you get excess growth hormone secretion as an adult. We all know Andre the Giant, or have maybe seen someone with gigantism. This is when it happens as a teenager. So in addition to the typical facial features, these people are 7 feet tall, and unfortunately, again, it goes unrecognized. There's actually one case we saw with a pair of identical twins, and one of the brothers was 7'3" and the other one was 5'10". One had gigantism, so it can be very dramatic, the difference between these two things. And again, often these things go for years and years and years undiagnosed. They just figure they're kind of slowly changing over time. They look at themselves in the mirror every day and don't really notice much difference. When it often happens is the things they say is, you know what, my wedding ring doesn't just fit anymore, and I've gone through 3 sizes of wedding rings in the last 5 years. Or my shoes just don't seem to fit anymore. Adults, our feet don't usually grow in adulthood, so if you hear something like that, it should be a clue to think, okay, maybe there's something going on. Maybe this patient has a hormonal overproduction syndrome. And then the other way people see it is if you look at a picture of their driver's license and you look back 10 years and it's gone 10 years undiagnosed, the difference in their facial features is dramatic. But it's all a matter of trying to tune into these symptoms, just recognizing patterns to try and get them to endocrine care earlier, so we can stop some of the permanent effects such as the cardiomegaly. So I'm just going to back up a little bit and go into a little bit of historical perspective. These hormonal overproduction syndromes, particularly acromegaly and gigantism, were known about long before we had the ability to do anything about them. There's descriptions of acromegalic giants back in the 1800s, and the first person to figure out that there was maybe involving the pituitary was based on a skull x-ray, and the sella in that patient was dramatically enlarged, so they think, okay, maybe this is involving the pituitary, and one thing led to another. Neurosurgery, as compared to other fields of medicine, and particularly surgery, is a very young field. So the first case of a surgery for a cerebral tumor was published in 1885. This was before the era of any imaging. They recognized this patient had left arm weakness. They were able to localize that to the central aspect of the pre-central gyrus and remove the tumor entirely based on his symptoms, which for the time was pretty amazing. Now, the patient died because of an infection. This is before the era of antibiotics, but what they discovered from that was it is indeed possible technically to intervene on the nervous system surgically and help these patients in the long run, and so the field of neurosurgery was born. Pituitary surgery followed soon after. Sir Victor Horsley was the first person to try to remove a pituitary tumor in 1889. Again, he diagnosed this via skull x-ray with a very expanded sella, and he did this via craniotomy, which, as you'll see, persisted for quite some time before we transitioned over to the modern approach. And then 1907, the first successful transsphenoidal resection of pituitary tumor was performed. But this was done very differently than we do it today. This required an external rhinotomy incision. So this is an example of how they did the first craniotomy, this incision on the face, drilling a hole in the skull and sneaking underneath the frontal lobe. This patient also ended up dying from excessive frontal lobe retraction. This is the original incision that was required for transsphenoidal, so obviously very disfiguring, requiring this external rhinotomy incision in order to get at the sphenoid sinus and remove the pituitary tumor. However, the field progressed relatively quickly in the early teens and 20s with the first successful sublabial approach endonasally, and also the first successful transsphenoidal approach. This is an example of the sublabial approach. An incision is made under the lip, and then the nose and middle part of the face are lifted up in order to access the pituitary gland. I've actually trained on how to do this as well, and many surgeons still do it this way, including Ed Oldsfield, who again is one of the masters of the field. So there's the next kind of stepwise progression of this was Harvey Cushing, who's considered the father of neurosurgery. He did over 200 cases of pituitary tumors between 1910 and 1925, all through the nose, all transsphenoidally, and with a mortality of only 5%, which for the time is absolutely amazing. By today's standards, I would be fired in a month if I killed 5% of my patients, but in those times, that's really, really impressive results. He recognized that the transsphenoidal approach was less invasive and had better visualization. However, Cushing was so focused on developing his microsurgical skills for the brain that in 1925, he outright abandoned the transsphenoidal approach in favor of developing his intracranial skills. And so in the case of Follow the Leader, Cushing was kind of the neurosurgical guru in the world at the time. Everybody, like lemmings, kind of went over the edge of the cliff and said, you know what, we're not doing this anymore. If Cushing's not doing it, we're going to stop doing it. And so it was a lost art. And transsphenoidal surgery was abandoned for more than 30 years. Nobody was performing it. Fortunately, in 1956, this was picked back up by one of Cushing's pupils, Norman Dott, where he performed 80 consecutive transsphenoidal operations for pituitary tumors with no deaths, followed by his pupil, Guillaume, who performed more than 1,000 of them. One of the big advances in the field was the introduction of the operative microscope. This is a huge advance for neurosurgery in general, but also for transsphenoidal surgery, and it really revolutionized the field because it went from using a headlight and kind of looking into this dark hole to allowing real illumination of the field and real magnification. So there's this kind of series of important players in the field, and I'm not going to go through this busy slide, but we've come a long way since that time, since in just about 125 years, we've come a long way in the development of these techniques. But, so that was then, and this is now. This is the, quote, modern era of neurosurgery, and you all have seen these patients out there with these horribly disfiguring incisions. These are both patients that actually had craniotomies for pituitary tumors, believe it or not. This is entirely unnecessary, but is still performed at many places. I would say this is no longer the norm, but this is definitely, it still happens, and you can see obviously these patients are not satisfied with these kind of results, and it's not necessary anymore. So I'm really kind of involved. One of my things is kind of pushing the envelope and advancing the field and really moving forward and maximizing what we can do through smaller and smaller openings. The field has been helped tremendously, even in the last 10 years, by technological advances such as intraoperative neuronavigation. This allows precision and accuracy of localization of the instruments to 0.1 millimeter, which if you're operating in a 2-centimeter space between the carotid arteries, being accurate is very, very important. Refined instrumentation. Dan Kelly, my mentor, was really critical in coming up with this instrumentation set for transsphenoidal surgery, using the Doppler vessel probe to listen for the carotid arteries, using ultrasound to visualize the tumors, and then the biggest thing in the evolution has been endoscopy. Neurosurgeons, although we like to think of ourselves as kind of way up here and smarter than everybody else, we're way behind the curve when it comes to endoscopy. General surgeons have been doing this stuff for 50 years or more, and we are just catching up to it now, and even still we're behind the curve. So in 1997 was the first series of, so only 16, 17 years ago was the first series of endoscopic pituitary tumor resection, so a relatively young field. And even in the last 5 years, the technology for endoscopes has advanced dramatically so that the visualization now, I think, finally supersedes that of the microscope. You can see the difference here between the visualization provided by an endoscope, which is introduced into the field and allows illumination of the whole field, versus, based on the principles of optics, a microscope where the beam of light is limited by the aperture you're looking through. So obviously, if you're looking through a small aperture, in this case working through the nose, introducing the source of light and the camera into that aperture is really critical for improved visualization and therefore improved resection. So I always talk about keyhole surgery rather than being a specific procedure or set of procedures. It's more of an idea, more of a way of thinking about things, with the idea being that we can remove tumors through smaller and more precise openings. This allows us to minimize manipulation of the brain, the scalp, the muscle, the soft tissue structures. That results in shorter hospital stays, less blood loss, and better outcomes. And this concept is really expanding, and again, we're trying to push the envelope of it to try and see how we can better help these patients. So I always tell patients when I'm kind of talking to them in the office, my goal in this procedure is not to beat my chest and say, I'm going to get in there and crack your head open and take this out. The goal is to kind of sneak in and sneak out and leave the patient exactly like a cat burglar, exactly as they are when we start. So there should be no evidence that I was there at all, with the exception they no longer have a tumor. So this approach started with transsphenoidal pituitary tumors and now has been extended dramatically. We can access tumors through the nose from anywhere from the frontal sinus, which we did last week, all the way down to the craniocervical junction and sometimes down to C2, depending on the patient's anatomy. But this allows a minimally invasive approach to removing midline tumors that are basically located between the carotid arteries all the way from the frontal sinus to the craniocervical junction, with a wide variety of pathologies, olfactory neuroblastomas, sinonasal carcinomas, meningiomas, craniopharyngiomas, Rathke's cleft cyst, chordomas. These can all be removed through the nose with the appropriate team and with the appropriate skill set. So in cases that cannot be removed through the nose, some patients do still require craniotomy for this. They do still require an open incision. However, rather than these big disfiguring incisions, we use nowadays a supraorbital craniotomy, which requires a small incision, about a 2.5 centimeter incision hidden within the eyebrow itself. This usually results in about 25 cc's of blood loss doing it this way versus typically a bicoronal incision about 1 liter of blood loss. These patients are usually in the hospital for 1 or 2 days versus about a week for a bicoronal incision, and the obvious cosmetic effects as well, which those of us here in Newport Beach, people tend to care about that a little bit here. So this is the incision we're talking about in those patients that do require a craniotomy. I should emphasize that this is uncommon for pituitary tumors. Less than 2% of pituitary tumors will require this type of incision as compared to an endonasal approach. But we do have it in our armamentarium in case it's necessary. So I always just like to put up this slide, which one would you prefer? These are both patients that had, this one had a craniopharyngioma, this one had a pituitary tumor which extended way up above the sella. And I always challenge people to tell me which eye that we went through, which eyebrow we went through. It's very, very difficult to tell. For those of you that are curious, it's this one. So all of these advances have been made possible by the introduction of the endoscope into neurosurgery and into skull-base surgery. The skull base, and particularly the pituitary gland, is situated at the very center of the head. So no matter how you go through, there's always many critical structures in the way to get there. So it requires using little damage to those surrounding structures as possible. But before we celebrate that the endoscope has replaced the microscope and this is the way to do everything, it's important to look at the results. So about 90% of surgeons are doing things now with the endoscope, doing pituitary surgery with the endoscope, even though most of them did not train on how to do that and they've kind of tried to pick it up and figure it out as they go, which with variable results. But this is from my university, this is a paper we did while I was in residency, a heads-up comparison, one of 2 outstanding pituitary surgeons, one using the microscope, one using the endoscope, and overall showed, this is for non-functioning pituitary tumors, overall showed no difference in outcomes, no difference in sinonasal outcomes, no difference in endocrine outcomes, no difference in visual outcomes. So it would tend to suggest that it's not necessarily whether you're using the endoscope or the microscope, but the experience of the surgeon and the training of the surgeon doing it and the training of the team supporting that surgeon. So this is, again, from University of Virginia, and the purpose of this is that some of you may have even seen videos of pituitary surgery and kind of you go in there and people do it and they stick a suction in there and kind of suck around, and these tumors are relatively soft, so you can get out 50–60% of it with the suction relatively easily, but those patients end up back in your office 2 years later because it comes back. Even though these are benign tumors, they recur. So the concept brought forward by Ed Oldfield was that these tumors don't have a true capsule. What they have is this thin rim of compressed pituitary gland surrounding them, normal gland, which acts as a pseudocapsule, which if you're careful enough can be used for a dissection plane to find your way around the tumor. The advantage to this is dramatic, and the outcomes are significantly improved doing this as compared to the standard suction technique, because when you go all the way around a tumor, dissecting it with the capsule, you know you've got it all out. You don't have to look around to see whether you've left little bits and pieces. It comes out as a ball in one piece, and that's the end of it. We do inspect afterwards to make sure there's nothing left, but you pretty much, you're much more confident that you've got it all out, versus if you're kind of just sucking in there and it's filled with blood, you really can't see, and therefore the chances of a total resection, which is especially important in the functional tumors, is much higher with this extracapsular resection as compared to a standard technique. So again, these results seem to suggest that it's the training and experience of the team, the endocrinologists, the ENT surgeons, the neurosurgeon, which is more important rather than the particular technique. The pseudocapsular resection is critical. Using this extracapsular technique in order to ensure that you've gotten all the way around the tumor is absolutely critical for ensuring outcomes to decrease your recurrence, to increase your remission rates. Remission in cases of biochemically active tumors like Cushing's and acromegaly, that's the term that we use. And that accurate diagnosis before surgery is absolutely essential. We find many patients that do end up getting surgery for prolactinomas, even though it's very, very well treated with medical therapy, because they didn't have a sufficient workup beforehand. So it's really about trying to do the right thing for these patients, and that's what we're trying to advance here at Hoag. And in moving forward in this, the data on huge series of these patients shows very clearly that centers and surgeons with specific training for pituitary surgery have much better outcomes. And until we started building this program here at Hoag, there wasn't one of those in Orange County. These patients routinely are going up to LA, UCLA, USC, or John Wayne for their care, and we now are building the team and are putting together the center to be able to treat these patients right here, and we certainly have the world-class facilities to be able to do it. So I'm happy to be involved as part of the team building that. So the next step forward, as I'm sitting on this panel establishing these criteria, you know, you see the term center of excellence out there, and people kind of hang their flag and say center of excellence, but many of these things don't have set criteria. So there's a team, a panel of us, including the team from UCSF, Stanford, UCLA, USC, Cedars, myself, all of the West Coast centers that are establishing these criteria now and basically saying that these patients really do get best treatment when they're treated by a multidisciplinary team. This is the list of the centers involved, and we're proud to be one of them. We are now defining these these criteria to establish these centers. And the biggest thing, the most important criteria, is having a multidisciplinary team. Again, gone are the days of I'm the neurosurgeon and I know best and I'm going to do whatever I want and not consult with anybody. The communication between the different members of the team is absolutely critical in this, and I value the input of each member of the team, and we're constantly speaking on the phone. What do you think about this? What should you do about this? Because I think that more and more we recognize this is a team sport, and that the outcomes are dramatically improved when we play it as such. So there are three main criteria to be established as a center of excellence: having the multidisciplinary team, which we have already worked and have been successful in putting together; educational efforts such as this, getting out there and educating and speaking with referring physicians, CMEs, community lectures, and nursing education, which we're also actively involved in, as well as research. And one of the things that we're really trying to get involved in is having an outcomes database, so we can continue to show that as a center of excellence at Hoag, we are able to we're the best place in Orange County to be able to treat these patients with these conditions. So we have most of the elements already in place. We are working to build this clinical database at the moment. We are looking to get involved in clinical trials. I know there's a couple of trials ongoing now for patients with refractory Cushing's that I'm working with the endocrinologist to establish, as well as a patient support group. And these patients really do need the support, particularly Cushing's patients. You change their life, and it's my favorite thing to do is treat Cushing's disease. You take out this 2-millimeter tumor and you add 20 years to their life, and you get rid of their diabetes and their hypertension and their obesity. But it takes about a year for them to thank you. They hate you for that year in between, because cortisol is like a drug. If you've had patients that are on steroids, they're energetic, they feel good, they're running around. You take that away from them and they are not happy for months and months and months, sometimes up to a year before they finally come in and they've lost 100 pounds in that year, and they finally come in and thank you. And it's a long road between those things, and so establishing a patient support group is really critical. So we're going to finish off with a case presentation, just a case we did about a month or so ago. It's a 52-year-old female. She presented with a 6-month history of visual loss, with the loss of peripheral vision, the kind of bitemporal closing fields as we discussed earlier, as well as headaches and fatigue. Now, headaches and fatigue, very vague symptoms. Somebody could have these for years and go without having an MRI. But she also had 150 pounds weight gain over 3 years, which is relatively dramatic. And again, they just didn't think much of it. They just thought she was getting older. I mean, she's only 52, but some patients put up with this kind of stuff for a long period of time before they seek care. And then even when they've been with their physicians, these things are dramatically underdiagnosed and misdiagnosed. So this is her preoperative MRI. We're looking at here a coronal section demonstrating about a 3.5 centimeter pituitary tumor. This little thin white rim here is the normal pituitary gland stretched way up over the top of the tumor, which is the typical pattern. And this particular slice, you can't see the optic chiasm. On this sagittal view here, again, we see the tumor here stretching way up, stretching the gland up. It's actually stretching the pituitary stalk, which normally goes downward. It's stretching that up. And then here is the optic chiasm, which is thinned out and compressed above the tumor from mass effect. So this patient had classic symptoms of bitemporal hemianopsia. Her hormonal workup revealed that she had both growth hormone and sex hormone deficiencies, as well as hypothyroidism. So 3 of the 4 axes of her pituitary gland, or the 3 of the 4 critical axes, were not functioning, which was responsible for her significant weight gain and fatigue and just overall feeling lousy. So this is the approach. We work up through the nose using the endoscope itself is 4 millimeters in diameter. We go through both nostrils. The endoscope gets introduced. Dr. Tim Kelly is my ENT colleague who does the approach, deals with the inside of the nose relatively gently, whereas as a neurosurgeon, I just kind of see it as a portal to get to the brain. He makes sure that we're gentle with the nasal structures, and the patients appreciate him for that. And then we get up to the sphenoid sinus. We open up the sphenoid sinus, which is actually a nice corridor. It gives us nice working space to get at the tumor itself. Again, we're working in a very small space here. It's only about 2 or 2.5 centimeters space, so less than an inch we're working between the two carotid arteries here on either side. And one of the known complications of this surgery is carotid artery injury, and when that happens, it's absolutely devastating. And then it's also only about less than an inch between the floor of the sella and the optic chiasm above, of course, unless, of course, the tumor has stretched it up even further. So overall, about 4 square centimeters here. We're working with in between about as critical as structures as you can get in the human body. So it's a very small space, and so seeing and having the instrumentation to do it and having a very clear picture of what we're doing is absolutely critical. So this is now, we're looking at the sella. This is the dura overlying the sella. Again, we're looking, carotid arteries are over here on the side. They're behind bone at the moment. But we're opening the dura of the sella. We use this very fine knife to do that. Lifting, then reflecting the dura up. This here with these vertical oriented vessels, this is the normal pituitary gland. Those vessels are 0.1 millimeter in diameter. So the visualization is very good. Now we're removing a small portion of the normal gland, cutting into it and lifting. You can see this thinned out crescent of normal gland. Sometimes we have to cut a bit of that away because it gets stuck to the tumor underneath. And we can start to see the tumor at the bottom of the screen here. So this whole thing down here, the more grayish aspect is tumor. We again start to go gently around the surface of the tumor. The goal here is preserving the capsule of the tumor, which is more difficult than you think. These tumors are very soft, but using this technique of very gentle traction, we're able to pull down the tumor from the pituitary gland above. You can already see the gland, which was thinned out before, has started to plump up again as its normal blood supply starts to fill it back up. This corresponds very well with return of function if the gland really starts to plump up like this. So again, we're doing this pseudo-capsular or extracapsular approach, going around it. Now we're removing the tumor away from the wall of the cavernous sinus, including the carotid artery. Indentation from the carotid artery is right here. That's the right carotid artery. You can see it very well there. This is the pituitary gland above. You can actually, once we pull it out, you'll be able to see the indentation of the stalk within the gland. So we're, again, preserving the capsule of the tumor in order to remove it as a goal of removing it all in one piece. When we are able to do that, to pull out the tumor all in one piece, again, as I said, the chances of recurrence are so much lower than if we do it in a piecemeal fashion. Now we're looking at the normal pituitary gland. There's a little knuckle up here, which is where the pituitary stalk inserts into the gland and kind of dents into it. We have the carotid arteries on both sides. So this is the left carotid artery and the right carotid artery. We're inspecting the cavity to ensure there's no additional residual tumor, although in this kind of case, I'm sure there isn't. And then we have to reconstruct the space, so we fill the defect. If there was a spinal fluid leak, which there was a small one in this case, we have to fill the defect with a small piece of fat, which we take from the tummy. And then the reconstruction continues. We lay down a synthetic collagen membrane in order to replace and reconstitute the dura. That gets laid down. This is a dural replacement substitute that we put down in order to reseal that membrane. We use the synthetic plate in order to reconstruct the face of the sella or the bone. And then we finish up. Sometimes we have to pack the sphenoid sinus with more fat, but this procedure takes anywhere between 3 and 6 hours, depending on the size of the tumor. The patients generally are able to go home 1 to 2 days after surgery. The outcomes so far have been very, very good. Let's see, I'm going to go back to where I was. So this patient tolerated the surgery well. She was no complications. We monitor them inpatient for diabetes insipidus, for adrenal insufficiency, for hormonal complications, for salt water imbalance, obviously for visual problems. She was discharged home on postoperative day 3. That's actually a little bit longer than usual, but she was almost 400 pounds, so we kept her an extra day just to make sure she was doing well. She had complete recovery of her vision in the PACU. So her visual deficit, or bitemporal hemianopsia, which was there preoperatively, was gone immediately. Within 6 weeks, her hormonal function returned to normal, and her headaches have now resolved. This is the kind of case which, unfortunately, with pituitary surgery, about 25% of what I do is redos of ones that have been done elsewhere, and they've not taken it out, and the patient has the tumor come back in 6 months, or in some cases, they've not even reached the pituitary gland, that the cella is still intact, and they told the patient they took it all out, and you look at the MRI and they've done nothing to help the patient. This is why it's so critical for us to establish Hoag as a center of excellence and really make sure that these patients are getting the best kind of care. So this is the pre-op and post-op MRI. These are the coronal sections here. This is the tumor beforehand with the normal gland stretched up over the top, and then afterwards you can see the fat packing there, which creates this void. The gland, although still somewhat tented up, looks more normal in appearance. It's kind of thickened up to assume a more normal, although not yet entirely normal configuration. As time goes by, this fat will shrink and the gland will continue to descend down to its normal position. This is a sagittal view of the same, again showing the complete resection of this tumor and the normalization of the position of the optic chiasm, which, as you remember, was stretched up here before, has now descended about 1 centimeter and is now in normal position, which correlates with her recovery of visual function. So, conclusions: there have been major advances in pituitary and skull-based surgery in the last 15 years and even in the last 5 years. This is just an example of that. Looking at, this was the endoscope technology that we had here 2 years ago, and this is the endoscope technology that we have now. Being able to see these microscopic vessels on the surface of the optic chiasm, almost anywhere else in the body, including most places in the brain, these blood vessels are meaningless. They could be sacrificed. On the surface of the optic chiasm, one of these tiny vessels could lead to a significant permanent visual deficit. And so visualization of these is absolutely critical. And fortunately, Hoag was able to bring in the state-of-the-art endoscopic system for our building of the program. And it's absolutely a critical piece of the puzzle. The second important point is that patient care is optimized when we work as a team, when we work as a multidisciplinary team. I welcome phone calls. Even if you're not sure someone has something, or if you suspect something, I welcome phone calls to discuss these kind of things. I look forward to working with you all and trying to take the best care of these patients we can. I do recognize these can sometimes be difficult to diagnose conditions, and that if we can work together to try and get these patients optimal care, then everybody wins. And that seamless integration between all aspects of the team is absolutely critical, and it's one of those pieces that will make us a center of excellence. And this is my little girl, my baby. Thank you for your attention.